Well, good morning, everyone. As Leo said, unfortunately, George couldn't be with you today, so I'll try and do his presentation justice. As Leo said, my name is Janette Hughes, and I represent the Digital Health and Care Institute. That institute is one of 8 innovation centres in Scotland, and Scotland takes innovation within this sector very seriously and has invested for the last probably over 10 years, but intensely over the last 5 years. What I'm going to try to do over the next kind of 15 to 20 minutes is really just run through where we are generally with integrated health and care and how digital will play a role. Some of the projects that we're focused on, and one particular area is the data flow and actually how that might harness that integration and accelerate it. So, our vision is very much echoed in most of Scottish Government strategies around this area, and that's really to help our Scottish population live longer, healthier and better lives, not just in the clinical settings, but out in the community. So probably not dissimilar to many of your strategies internationally. The other thing that we're focused on is very much economic development. This is a growing market opportunity, and I was delighted to see so many industry exhibitors outside. And we're very focused on not just exporting our innovation, but also to attract people into Scotland. So the way we do that is actually by bringing people together. We have what's called the quadruple helix with regards to who we bring together. So we work for the public sector, the civic community, and that includes health boards in Scotland. It also includes local authorities, commonly known as municipalities throughout Europe, and the third sector, who play a really important part in actually this agenda and shouldn't be ignored. We also include our academic colleagues throughout Scotland and our industry players in Scotland and out with, but most importantly, we engage with the citizen to try and understand their voice and their opinion and how this agenda can move forward. In Scotland, there's many different strategies that pulls together the integrated health and care agenda and the digital aspect of that. Some of you will probably have heard of the digital health and care strategy that came out a couple of years ago and it has now been implemented in Scotland. Some of you might not be as familiar with the realistic medicine strategy, and this was endorsed and written by our Chief Medical Officer, Catherine Calderwood, and I think it really does bring together some of the drive and ethos around integrated health and care. One key point it makes is the shared decision making and actually allowing the sector to innovate and be creative and potentially take some risks around that. So that's one that if you haven't already read it, it's definitely worth a read. So, like everybody in this room, I suppose the key challenge for us all is illustrated behind me. And that's really, how do we shift the balance of care? How do we move to a more proactive, predictive and prescriptive model, and not just in the clinical environment? How do we move it to a much more focused model on the edges? How do we prevent things like diabetes? How do we prevent or make early diagnosis of certain conditions and diseases? But fundamentally, how do we actually move people through the care continuum? Which is, how do we do a seamless handover from all stages? And I think that's key to this integration agenda. And certainly, if you read most strategies in the world, this illustrates what we're all trying to achieve. I have been doing this for the last 10 to 12 years, and I know this is difficult. And I'll talk a wee bit about why I think it's difficult. I think most of it has been covered over the last 2 days in the excellent presentations, but I'll just give you my take on DHI and how DHI is actually helping on that journey. The other big driver is not just shifting the balance of care, but actually embracing some of the digital technologies. We see things like IoT, the Internet of Things. We see new communications coming through, like 5G in the next couple of years. Data plays a really important part, and it's a common strand throughout everybody's world. Doesn't matter if you're in the third sector, doesn't matter if you're a consumer with a Fitbit collecting your own data, it doesn't matter if you're a GP or a pharmacist, you all have data. I suppose one of the great barriers around this area is the sharing of that data. The other thing I'd like to say is, and we talk a lot, and we have talked a lot for 10, 15 years about the demographic shift, which is a real key importance factor. However, what we can't forget is the expectation of the future generation. They expect integrated health and care. They expect data to be aggregated, and they expect data to be used with their consent to make their lives better. So there has to be new ways of working. It's not just about sustainability, it's about expectation. Another key point is the whole system point, and I think there was a question yesterday about smart cities. I used to work, or had done for 2 years, in the Future City strategy, and I've gone all over the world, looked at cities, and obviously health and care is key to every city, but you've got to think about the whole system. It's, again, not good enough just to think about health and care. You've got to think about transport. You've got to think about the environment. You've got to think about housing. So, again, that integrated health and care agenda spans much broader than possibly we're all considering just now. And it's really important to think about it, because actually you could uncover budgets that will assist and accelerate this process. The integration of innovation is something that I'm very passionate about. 10 years ago, I used to run technology projects, trying to find a home for technology in this health and care world. And over the last 5 years, what I have realised is that there's 3 kinds of innovations for this sector. There's the service innovation, which we're all talking about and is key. There's the technical innovation, which we see around us and we see the opportunities. And then there's the business model innovation. And actually, it's the converging and merging of all these 3 innovations that will start to make this market and opportunity be realised. Some of the work that we do in DHI is much more focused now around actually, is the service ready to change? And that is a really key point. Is there enough change management, change appetite to actually do things differently, to work more collaboratively and to work together to actually for the greater need of all? So for me, it's not just about technology, and it's not just about the interoperability of technology. It's about the interoperability across these services, and that's a key challenge. In Scotland, we have integrated joint boards, and that's a new model introduced about 2016, and that is trying to bring health and care together. So we're only starting to see the benefit of that just now, and I think, again, that will move this forward. So what is it we actually do? Well, again, there's been quite a lot of discussion about what's driving this sector. And for DHI, we were very much supply-driven. We are now demand-driven. So we look at the health board strains, we look at the local authority, municipality pressures, and we actually ask them what their greatest demands are so that we can actually take the pain out of the system and help to get the greatest impact and see the benefits. We use tested methodology, and I suppose the key point for this is it's agile. This is not a sector that will accelerate quickly unless you have adaptability and agility to actually move it forward. But really what the focus for us is greater adoption of digital health and care innovation and the scalability of that innovation across the board. I've really enjoyed listening to a lot of the kind of co-design presentations and looking at some of the posters, and delighted that DHI have been using co-design for the past over 5 years, and we are focused on that. We start with what is it that the server users' views are. Where is the biggest demand and problems? And that includes practitioners, that will include social workers, that will include pharmacy, pharmaceutical people, so that whole broad spectrum. And what we try to do there is actually develop personas for some of the challenges that we're trying to focus on, so that we understand the journey from a lot of different perspectives. We've got lots of projects. We've got over 100 projects that we've delivered in the last 5 years. And some of the bigger, more transformational projects have been delivered in the last 18 months. Some of them are from a focus of how do you reduce and prevent things happening, like stroke reduction using digital atrial fibrillation detection. We look at the pain points with regards to waiting times or the transfer from one health sector to the care sector and how you can actually introduce digital. But one of our key focuses has been in the last 12 months, because it comes up time and time again, is actually the citizen-centred data sharing agenda. And it comes up in every conversation, irrelevant if you're speaking to a clinician or a patient or a carer or the social worker. The frustration around this area is enormous, and actually we believe it's one of the big barriers to integration. So that's what I'm going to focus on in the next kind of 5 to 10 minutes. So DHI really creates a space to challenge the norm. And I think, again, the keynote speaker from yesterday said, sometimes you don't have time to think. Sometimes you just are in delivery mode. So this is really Scottish Government and Scottish Funding Council, who fund us, has gave Scotland the opportunity to have space to think and actually think differently, which is key. When we think about citizen data and we think about the challenges around it, what we've done in the past is that we look at best practice. We're a wee bit like a think tank for partners. So we looked at Estonia's model, and we went there about 2 or 3 years ago, and we understood what they were doing. And then we had a look at Finland's model to understand, okay, what Estonia's done around interoperability, driving it forward. And of course, Estonia had their president sitting on the board with regards to that drive. And Finland, again, has got a more focused model on social care data integration as well. So we learn a lot from looking around the world. And again, I've picked up great things from being here for the last couple of days. Once we have an understanding of what's happening around the world, we do co-design. And this is this is a project in front of you called Backpack that we did, and that was to gather patients, practitioners, that actually, with a focus on MS patients, to say, okay, thinking about your health story, thinking about your life story, thinking about the things that would help you most, what does that look like? And we use kind of paper prototypes and tools. We have a very active design team that really allows people to think differently and be creative. And what that showed was that data, again, was at the heart of it. Firstly, people thought data was shared between health and social care. So they thought we were probably doing a wee bit better than we were. But the other thing that was surprising was it wasn't all about health data or social care data. It was about other bits of data that they wanted to transfer across. Things like, what would make my life easier if I'm asking the benefit or welfare system to support me? Why do I need to tell my story again? MS is a condition that you're not going to improve from. Therefore, why can I not have a token in a health record that says I have MS, that makes that whole system aware of that condition and reduces duplication and frustration within that system? People say they want access to their health records. What they don't want is access to this, because it means very little to them unless you're a clinician. What they want is something that's user-friendly, something that allows them to get on with their life, something that allows them to share with whoever they want to share with, whether it be their sister, daughter, whoever's looking after them, next door neighbour even. So that integration is a lot wider than this statutory service. What they also said was navigating the system is an absolute nightmare. I hope that translates. And I think that's maybe key, common in every setting internationally. And the quality of the interaction, if your GP spends 8 minutes speaking about generally how are you, they have 2 more minutes to try and solve the problem that you've came with. So how can that data make it easier? We all know as well there's invisible resources, and what I mean by that is the third sector, your next door neighbour, that social connection that can be made. Again, allowing your data to be transferred and used can maybe actually matchmake you with something that will make you happier, not just from a clinical perspective. I'm not going to go over this because I think we all know what the common barriers are, and there are many, and they've been around for a long time, so I'm not going to dwell on that. But what we're doing, I'm just going to flick through very quickly. We're building a trusted and distributed collection of data, and we're doing this in such a way so that we can prove it can be done. We're using co-design to make sure that we're taking the views not just of the citizens, but of practitioners and others that are in the ecosystem. And we're trying to develop decision support so that that makes it easier for everyone. We have in DHI a new development which is an asset, and it's a demonstration and simulation environment. And the reason that we developed this is that we believe to accelerate this sector, you have to simulate. Now that means that you de-risk. So rather than doing it always in live settings, rather than trying to argue your case by pointing to 5 papers that says, actually, this can be a reality, what we do is we actually simulate the transfer of data. We use key principles when we're working with partners on that, so open data standards. We try to preclude legacy systems only. We try to make sure that everybody's signing up to these principles so that we can move the market forward. And what we then do is we actually showcase health boards, local authorities, third sector organisations, and what the future might look like. So the art of the possible. which again, going back to time, people don't have time to think about that often. When it comes to data and what we've done in the simulation environment, what we've actually simulated is not just a transfer of data between a health board and a local authority. We've taken it that one step closer to the citizen who is telling us that they have citizen-held data. They have it in their Fitbit, they have it in their wireless blood pressure monitor, and they want to share that with their health professionals, their carers possibly, their dietitians, whoever it might be. So we have actually developed an exchange layer that allows the transfer of data from consumer devices that the citizen has bought to the statutory system. And the project and organisation we're working with is Greater Glasgow and Clyde, who are one of the biggest health boards in Scotland. And we have proved this. Now, the reason that we've done it is because people say that can't be done. It can't be done in the health and care sector. It's too difficult. So we've had to actually invest and prove by using open standards like HL7 and FHIR. We have actually developed something that does transfer data in real time from devices to the statutory system. So one case study that I'll go through very quickly, I'm not sure about my timing, so I'm hoping I'm not running out of time, is hypertension and high blood pressure. We've all got a cost around that. There's a lot of people that are actually spending a lot of time taking blood pressure in GP surgeries, and it's costing a lot of money and consuming a lot of resources. So what we've actually looked at through our design process is what the current state looks like, and the current state is what you see on the slide behind me, and what the future state could be. So that future state, again, going back to the transfer of that data, you could have a token, you could have a wireless blood pressure monitor that starts to send information. The citizen could add some family history themselves, and we could develop and introduce algorithms that actually starts to look at that intelligently. So this is the organisation, what it does today. This is what the citizen's doing, and you'll see the big gap in the middle is really what we're trying to pull together. So we're trying to pull together the statutory and the citizen data for the benefit of the patient. Again, this is just another view of what the future world might look like. So we start bringing in potentially things like machine learning and data analytics, data science to actually predict problems before they even happen. I'm going to flick through this very quickly. I'm looking at Leo to say what timing. Yep. So asthma is the same. I'm not going to go into it in great detail, but I'll just make a point on this slide that, again, going back to the whole system, if you think about asthma and what affects asthma on a daily basis, things like the weather, the environment that they live in, if you pull all of that data together, you could actually start from a public health perspective, sending intelligent and predictive information to that cohort to stop asthma attacks, for example. What I'd like to end on is the kind of industrial revolution. We believe at DHI that there is a Care 4.0 revolution, and I think we all know about the industrial revolution, so 1, 2, 3. We're now on 4, and for anybody that knows about manufacturing, Industry 4 is the title of that. We believe that Care 4.0 is here. And that is very much about flexibility, the person, co-management and empowerment. So if you want to read a bit more about that, there's a paper, if you Google it, you'll actually, I think we come up #1 in Google just now for Care 4.0. So to end, I'm probably ran right over time, What we are here to do is actually meet the future demands, not just of those in the room that are health and care practitioners, but the future demands of our citizens and that generation who are 20 just now, who will not tolerate the lack of integration. Thank you.